So good afternoon. Our group project is for the following team members: Celia Espinosa, Daniela Fontan, Gisela Miranda, and Juan Carlos Moldes Cruz. We have selected the ethical issues, the healthcare provider-assisted suicide. Well, first off, I'm on the important group, the issue part. I think in healthcare provider-assisted suicide, it is acceptable. Because number one of the most common arguments in favor of legalizing it is the respect for the patient autonomy. I think it allows the patient the right to choose the manner and the timing of their death, particularly when they're suffering from a terminal illness. It can also be seen as an act of compassion and beneficence, because it alleviates unbearable pain and suffering. Obviously, this is very linked to the autonomy. Still, on the autonomy side, autonomy, I think it refers to the patient's own governance over his own actions. So in the healthcare setting, this means that the patient determines which medical intervention he's going to elect or not elect. So it serves as the justification for informed consent. And I believe that this logic naturally extends to the topic of provider-assisted suicide. And because patients are accustomed to making their own health care decisions during their entire life. So I also agree that they should be permitted to control the circumstances of their death as well. I also believe that I know that there are some people that may believe that this forcing of the individuals to endure prolonged suffering violates their right to a dignified death. And in certain states where this is legal, there are certain strict guidelines to ensure that it is only available to those with a clear, sound decision-making capacity. And whenever there's a terminal prognosis, and this provides safeguards against abuse or malpractice. If anybody wants to add in anything, just feel free.
I also wanted to add that I found out that here in Florida it's not currently legal. So that is a barrier that patients that have terminal conditions face here. They're not able to have this option for them to have physician assisted suicide.
Okay, yeah. Okay, go ahead.
I'm Celia, and I am going against physician-assisted suicide. So I believe that physician-assisted suicide violates the ethical principle of non-maleficence that obligates us healthcare providers to do no harm. So assisting a patient to end their life, even at their request, can be seen as an ultimate form of harm, just because the patient may be going through a lot of emotional challenges, which can make them feel like the only option they have is to die, when there's other things that we can do to make them feel better, like palliative care. A lot of people also argue that it undermines the sanctity of life and could lead to a slippery slope where the value of human life is diminished, especially for vulnerable populations like the disabled or elderly. As I was mentioning before, there are alternatives such as palliative care and hospice that can manage pain and suffering without hastening death. I believe that there's a difference between passively letting someone die and actively, quote unquote, killing our patient or ending their life. Another thing is religious and cultural beliefs also play a big role because a lot of people, including myself, believe that life should be preserved until its natural end. And if anyone wants to add anything, they could.
My name is Gisela Miranda, and I'll be presenting why healthcare provider assisted suicide is not morally right and ethical in the healthcare profession. The debate over healthcare provider assisted suicide, even in the context of promoting death with dignity, involves several complex and sensitive issues. And here are some reasons why some people find it unacceptable. Number one, as I said, there's moral and ethical concerns, and that is because many people believe that taking life over, even with consent, violates ethical principles. And also, healthcare providers may feel that their primary role is to preserve life and not to end it. Number two, slippery slope arguments. And what I mean with this phrase is that one action could lead to another unintentionally. This means that allowing assisted suicide could lead to broader practices where vulnerable populations such as the elderly, disabled, or mentally ill may be pressured into choosing death over life. Number three, potential for coercion. It's possible that patients will feel under pressure to choose assisted suicide because of expectations from their families, financial strains, or social perceptions of what constitutes a good life. Number four, inadequate mental health support. And this is for people experiencing extreme despair or anxiety may turn to assisted suicide as a means of escape rather than getting the essential mental health support that they really need. Number five, informed consent issues. It may be difficult to make sure that patients fully or completely are aware of the other alternatives and the consequences of making their decision. And informed consent may be compromised by miscommunication or incomplete information. Other opposing ideas are the impact on healthcare providers, including medical professionals, and assisted suicide may cause more discomfort in those who are unhappy with the practice, which may have an adverse effect on their mental well-being and content at work. Number seven, alternative palliative care options. Studies shows that enhancing pain relief and palliative care can help people pass away with dignity and avoid the need for assisted suicide. Number eight, religious and cultural beliefs. Many cultures and religions consider life as sacred, leading to strong opposition to any form of assisted death, which makes them strongly opposed to assisted suicide in any form. This can have a negative effect on social norms and values. Number nine, legal and liability issues. Putting assisted suicide into practice presents difficulty, legal questions, and may make medical facilities and providers liable, which will make caregiving more difficult. And number 10, loss of trust in healthcare. People may worry that their doctors are considering helping them to die rather than looking out for their health and welfare.
Okay, it's not that I completely disagree with you, but I think that patients should have the choice to decide. Um, I understand that hospice care and palliative care are important, and they should be there available to the patients. But I think that ultimately it is your own. It goes down to their own individual. They have to, if they have the capacity, the mental capacity, to decide if I get to this certain stage in my illness and it's irreversible and I'm not going to get any better, and from then on I'm going to suffer more. If they have the capacity and they have the willingness to do so, I believe that should be respected.
Okay.
I also want to bring some clarification to when the opposing team mentions that there would be a slippery slope with the disabled and those kind of patient population. I think that, as Frank Carlos mentioned earlier, in other states where it is legal to have physician assisted suicide, there are certain guidelines that are set for the patients that have this option available to them, such as those that have chronic, irreversible, diagnosed concerns or medical health issues. This is not something that's going to just be open to any and all living people. This is something that is used when there is no medical treatment, no cure left to help this person, and inevitably they are going to pass.
Okay. I believe, as the opposing person in this debate, that I still strongly believe that there is other options. Death feels absolute, and personally, I feel like it goes against our ethic to, give patients no harm. But I respect your point of view.
Yeah, well, I still continue to respect your point of view. I think that the principle of having that capacity of an ability to decide what you want to do with your life should be respected at all time. And I don't think like religion or personal values should interfere in the patient's decision and willingness to do this. And I understand this is a very controversial topic, but I'm a strong advocate for the patient's autonomy. I think that's for me that's number one, and it should be respected.
Okay. Does anyone want to add anything else?
If you want, I can present a very personal case. My aunt, like many years ago, she suffered from cancer in the liver, and well, she was like following the treatment and all that. She was doing pretty good, but at some point, the illness, cancer spread like very bad, and I saw all her suffering. And believe it or not, although some family members, some of us were trying to cling on to the idea that she was going to get better. She wasn't going to get any better, and I saw all her suffering, all everything she went through, and I didn't have the autonomy. I didn't have the legal capacity to decide. And this wasn't back in my home country, which is Cuba, and this is something that is not done there. But had I had the opportunity, she was my aunt. Had I been her son, and had she wanted to do, to take that decision of provider assisted suicide, I would have moved forward, because that's the memory of her suffering has always followed me through my entire life, and that is something that I cannot get rid of.
I'm so sorry to hear that, Fran Carlos. Thank you for sharing that experience. I think that that also really goes with what we were talking about earlier, that patient autonomy is very, very important. Being able to give them the right to be able to make their own decisions regards to their body and their life, it's very, very important. And I understand how this can come to collision with our other ethical duty as nurses of non-maleficence, but we need to sometimes think about how there's always going to be laws set in place that and restrictions that this is not going to be something that just becomes normalized and is available to everybody. We don't just take people into the hospital and just give them random treatments. There's a certain set of guidelines. For instance, when we have stroke patients come in, we have to check if they're a good candidate for receiving TPA. It's probably, I know it's like not the same comparison, but it's something similar to show that in medicine we have criterias, and there's always going to be that for everything. And if a patient does not fall under that, they are not going to receive the treatment or whatever it is. So I think that it's really, really important to be able to provide autonomy to patients and allow them to make decisions for themselves. And this is something that a lot of patients that have chronic conditions, like Fran Carlos mentioned, that it's very important for them and to provide this for them.
I am also very sorry to hear from Carlos. That is very sad. But I still, as the opposing person and talking about diagnosis and illnesses, there's also a lot of physicians that have made mistakes in the past, which include an error in a diagnosis or like prognosis, which we really can't tell someone like the exact time when they're gonna die. Which giving the wrong diagnosis to a patient can lead them to depression and inadequate treatment, and these type of mistakes can result in an unnecessary death, because when the patients get these type of diagnoses, it's like you like take away their hope, and the first thing they want to do is just like, I want to die. And I feel like we have an obligation to protect lives from these mistakes that can happen.
I
I think it's
completely, oh, sorry.
no, you go ahead. Sorry, go ahead.
I completely understand where you're coming from. I think that mental health is very important to include in this discussion. And I think that it's also important to consider, for instance, what usually happens, at least here in Florida and other states that don't allow physician assisted suicide. Most of these chronically ill patients go to hospice centers. And if we also think about the mental health of the family and the patient themselves when they are going through these last moments, because hospice care is just palliative care where we are just basically comforting and aiding them to their deaths, but their mental health during that part as well, and the family members seeing their family, their dad, their sister, anyone go through these things, it must also take a serious toll on their mental health. And as nurses, we don't just provide care to patients, we provide cares to their family as well. That's why I think that it would be very beneficial, not for all patients. Additionally, from the criteria, we'd also always have the patients get the choice of whether they want to participate in physician assisted suicide. It would never be something enforced upon them. It would very much be like anything else where we allow patients to pick if they want to refuse treatment or medication. It would be completely up to them, but I think it could also be a benefit to their mental health and their families.
I totally agree with you on it. Honestly, I do.
And in addition to this, I want to add a personal experience as working as a nurse in a med surgical unit. It's that we get sometimes patients that are hospice patients, and it's sometimes, sometimes ending the life, it's not the solution. I think that if we can preserve the life until the very end and just treat their symptoms for of the disease, of the condition that they have, and in a way that they can still enjoy with their families, it's a way that we as a providers can help them um, to have um, to have a solution to this, because I think the main concept of medicine, of nursing, and healthcare, it's to promote health, it's to promote dignity, it's to provide also hope and positivity to those people. Some people may think that is the end of the life, and sometimes they can, for example, the doctor can say, okay, your expectancy of life may be just 6 months, but let me tell you, sometimes that's not God's plan, and sometimes you can live more than that. And some people may think that, okay, I'll live so just 6 months and that's it. Or if I have cancer, I'm gonna die for sure. No, that there is possibilities that we can treat you with chemotherapy. We can treat you with a lot of things that even it seems that you are declining in health. Actually, with the time and process and positivity, you can get better and you can get out of this. But may not be the very last resource. Just go straight in there and die. Um, so with this, I'm saying that even though your expectancy of life is 6 months, it may not be that. It may be a just an estimate of when is expected you to die, but actually it cannot be. Sometimes people live longer than their expectancy, and that's why we gotta provide hope instead of just giving them the solution of die. And I think we as a healthcare, we shouldn't be we shouldn't be helping people to die. We should, is that it will be like we're helping them to commit suicide, or we're killing them. I don't know, that's my perspective. But I think we should help them to get to the process of them dying themselves, and with family, with dignity, and with comfort. I think that's the way I see it. So that's the way.
As we were discussing anyways, the ethical debate around the physician assisted suicide, like I mentioned, is the balance between autonomy and non-maleficence of a patient. So obviously respecting the patient's autonomy is basically you just honoring their right to make decisions about their body and life. And this includes the choice to end their suffering from any chronic condition through physician assisted suicide. Then, however, non-maleficence presented by the con team makes the challenge that the potential harm as nurses that we could be doing by taking an active role in ending their life. Fran Carlos, you want to read the last point?
Sure. Says beneficence suggests that easing a patient's suffering may be the most compassionate course of action, but it must be weighed in against justice, which involves fair and equitable treatment for all patients, including vulnerable groups that might be at risk if the PASS becomes normalized. Again, I think that aid in dying is not euthanasia. It's like you're helping somebody die, and the way I see it is that if in the same way that somebody who's like brain dead and that will never it's in a coma state and then it will never it has to be disconnected. I think that if the family makes the decision, I think the patient has the right beforehand gets into to that point to do so. And when they mention the topics about the vulnerable groups, again, this is a very serious topic. This is something that should not be should not be taken lightly, and has to be closely monitored by both healthcare workers and family members.
So when you read, beneficence suggests that easing a patient's suffering may be the most compassionate course of action. I don't I don't necessarily believe that it has to be by ending their life. Like I said, we have palliative care and hospice care, and I believe that patients can still have some quality of life, and they don't have to end their life abruptly. Like they still could have a good few months left of life, and they'll feel good if we take these measures for them to be comfortable, and that's
But
what I think.
but do you think that what if the patient doesn't want to have that those few months extra? Don't you think that they should have the ability to choose?
Of course, I just personally think that death should not be like the first choice.
Agreed. Um, maybe we could find like a halfway point in this topic, and try to find a way to advocate for the patient, and at the same time, have those other services like hospice care and palliative care available, and for those who do want to take that route.
So now we have implications for nursing practice. So for nurses, physician-assisted suicide presents a unique ethical challenge. Like I was mentioning before, nurses are bound to uphold the principles of patient advocacy and compassionate care. And this might conflict with their personal beliefs or obligations as nurses. In jurisdictions where PAS is legal, nurses must navigate their roles carefully, ensuring they provide non-judgmental, supportive care while respecting their autonomy, of course. Um, and they must also maintain clear communication, emotional support, and provide access to all end-of-life care options, including hospice and palliative care. Nurses may experience moral distress when involved in physician-assisted suicide cases, which underscores the need for ethical guidance and emotional support within the healthcare team. So, as we've been mentioning before, this really is a topic where, we're between what's ethically right and what is like the best thing for our patient. I think it's a really complicated topic, and everyone has different beliefs.
I really agree with that perspective that you brought up, where you are talking about the mental health of nurses. That's not an aspect that we had considered. However, I do believe that nursing is very versatile and we have a lot of different specialties throughout our nursing career. I feel that similarly to how hospice and oncology and some of those specialties for nurses where they have to work with chronically ill patients, those can take a toll on their mental health, and it's really not talked about often how working in specialties like those can affect nurses. But I feel like in light of recent years, we have become more aware of these issues, made more advances to prioritize mental health. And I think that if we were to have physician assisted suicide, there could be nurses, like a specific nursing specialty for that, or that it will be something provided already in a specialty that deals with end of life care. So it would be nurses that already do have more experience with this kind of situation, and having to handle these emotions that come with losing a patient. So I think that it would be very, it could have mental health issues, but we also have to think about the patients and how, what they may be going through, and what, how we could offer that, and it will be like a relief to them. And we just have to consider all of those aspects.
Yeah, I agree. I just wanted to add in really quick that and it is a very taxing work for nurses, and that it could have on a profound psychological, emotional impacts on nurses as well. That's why they should also be provided with the opportunities to openly speak and talk about it, and have also education and counseling as well in case they need help.
Yeah, you bring up really good points. I feel like for this type of situation, it'll be like running a code like 10 times a day. And a lot of nurses have, said how emotionally draining and taxing it is to even do a code on one person and lose one patient. Now imagine you doing that every single day. Um, so it is very tough.
Well, as we mentioned before, we would not allow physician assisted suicide to be something that is so normalized where it is occurring every day. I think it would be something that, again, we'd have to make sure that diagnoses are correct, have it approved through numerous physicians and healthcare team members, not just, gonna become something that's constantly like a regular thing. It's gonna be a serious decision, maybe something that, to ensure that the patient is in the right state of mind, have them put in their decision and allow for 3 weeks to pass, and then maybe consider it once the 3 weeks pass for it to be in order, or some mechanism like that, something that doesn't allow this to just become something that's very facilitated or easy to acquire. Again, maintaining the criterias of making sure that it is a chronically ill patient who will be receiving the physician assisted suicide. All these things are very important to consider and to make sure that we abide by. So, personal reflections for the pro team. I think that we truly believe that patients could benefit from having physician assisted suicide. I think that it is an option that we should allow patients to have. I strongly believe in autonomy, and I think it's very, very important to be able to honor a patient with their right to choose what they want to do with their body and with their life. I feel like in nursing, we are taught very in depth to provide patients with autonomy and to allow them to be part of their healthcare plan. And we emphasize the right to refuse things, like the right to refuse medications, procedures, and this is all very, very protecting the integrity of a patient's autonomy. And I believe that if we allow physician assisted suicide, this would be another way for patients to exercise their autonomy rights in the medical field. Frank. Carlos, do you want to add anything about the pro?
No, I think you were like very, very thorough in your explanation. Now, I think you covered everything.
So, reflections for the con team. I will say that the pro team brought up to my attention a lot of things that I hadn't thought about before. So I will definitely look into it. But morally and ethically, feel like physician assisted suicide would be morally wrong. That's how I personally feel. I do feel like there is other options to give the patient a quality of life, you know, treat their depression, you know, I think actively taking our patients' lives is not something that I agree with, but um like I said, the pro team brings up really good points and I totally respect your views, but personally I don't feel like PAS is with my integrity as a medical professional.
Well, I think as a conclusion, healthcare provider says that suicide is a very controversial and contentious issue that challenges the boundaries of patient autonomy, ethical caregiving, and the role of healthcare professionals. Uh, Both the pros and cons sides, they present compelling arguments, and that range from the respect for personal choice to the sanctity of life. While provider-assisted suicide raises significant ethical concerns, it also highlights the need for improved end-of-life care and patient advocacy. Advocacy. I don't know if Daniela, you want to add something, or Cecilia.
No.
No, I think we're okay.
These are our references for our presentation and debate.
Thank you for watching our debate.
Thank you.